Hello everyone, this is Miss Glenn coming to you live wherever you may be watching this. Mark yourself safe from the coronavirus. This pain lecture was meant to be in the classroom, but we're going to do it online given the circumstances. So I'm going to try to do the best that I can. It's going to talk a little bit about stress, the effects of stress on the body, how we can help our patients manage stress along with ourselves. We're going to talk about pain, assessing and managing pain levels in patients. We're going to discuss some about substance abuse, and then we're going to do some questions and answers at the end. So here we go. No matter who we are, patients, students, caregivers, teachers, stress affects us all. Stress has a powerful effect on the mind. It affects many of the body systems, so its effect is very significant to one's overall health and well-being. In this section of the lecture, we are going to focus on how stress affects the mind, body, and how to effectively deal with stress. Stress is defined as the inability to cope with perceived, whether real or imagined demands or threats to one's mental, emotional, or spiritual well-being. Each individual perceives situations differently, so what is stressful to one person may not be stressful to the other. Stress is linked to leading causes of death, cancer, accidents, and suicides. Stress first affects the mind and then the body, our health and well-being. Stress has been linked to cancer, accidents, and suicide rates. It's estimated that 1/3 of Americans live with extreme levels of stress. Stress is a response to demands, our perception that one cannot adequately cope with demands being made on person or well-being. Stress is also perception and personal meaning of how a potential stressor influences the response. Stress is subjective. The same stressor can be perceived differently by different people. For example, one person may be excited about a promotion, but someone else might feel stressed about the added responsibilities. Or one person may be excited and happy to go on a trip to the beach because they feel it will be relaxing, when someone else may have a lot of anxiety about traveling, maybe due to the fear of flying somewhere. There are two types of stress, either physiological or emotional and psychological. It can be acute or a chronic problem. And the intensity can differ between either mild stress levels, moderate, or even to severe stress levels. A few factors that can affect our response to stress are resilience and attitude. When someone is resilient, it means that they can be resourceful, flexible, or they have very good problem-solving strategies. A high degree of resilience means that someone is less likely to perceive an event as stressful or taxing. With attitude, we have two different types of attitude. We have optimists and we have pessimists. Optimists are more likely to cope effectively. They're less likely to develop stress-related illnesses, and they recover quicker from illnesses as well. Pessimists are more about denying the problem, or they distance themselves from everyone. They focus on their stressful feelings and allow stressors to interfere with their goals. Positive emotional attitude can prevent disease and prolong life. With a strong support system also helps someone cope with stress more effectively. The General Adaptation Syndrome, known as the GAS, is our body's physiological response to stress. There are 3 stages. The first stage is the alarm reaction. Our body releases adrenaline and a variety of other psychological mechanisms to try to combat the stress and stay in control. This is called the fight response. With the fight response, our muscles become tense, our heart tends to beat a little bit more rapidly and harder, our breathing increases, our eyes tend to dilate, and our stomach may clench or even start cramping. Believe it or not, this is done by nature to try to protect you in case something bad occurs. Once the cause of the stress is gone, the body will go back to normal. In the resistant stage, it is ideal to transition from the alarm to the resistant stage fairly quick. Our patients should present with a few overt physical symptoms that occur with this stage compared to the alarm stage. In this stage, either adaptation occurs or the patient advances to exhaustion. The body's response with exhaustion can go to long-term protection due to long implication of stress. Our body secretes further hormones that increase our blood sugar levels to sustain energy and raise our blood pressure. Our adrenal cortex produces corticosteroids. We go into overdrive by the body's defense mechanism and eventually leads to disease. If this adjustment continues for a sustained period of time without pauses of relaxation and rest to kind of counter the stress response, our patients are going to be prone to more fatigue, lethargy, concentration lapses, and irritability. Exhaustion is the final stage of the GAS. It occurs when all energy for adaptation has been exhausted. Physical symptoms of the alarm reaction may briefly reappear in the final effort by the body to survive. In the stage of exhaustion, there is nothing left. All energy has been expended. It's very common for patients to become ill and even die if they don't receive help from the outside. This stage can be reversed by external sources such as medications. In this critical stage, the body runs out of its reserve of body energy and immunity. Our mental, physical, and emotional resources suffer heavily. The body experiences adrenal exhaustion, meaning our blood sugar is going to decrease as the adrenals become depleted, leading to decreased stress tolerance. Progressive mental and physical exhaustion will continue and will develop illness and collapse. Coping is a person's cognitive and behavioral efforts to manage specific external or internal stressors that seem to exceed the available resources. There are two types of coping, positive and negative. Positive activities such as exercise and the use of social support, and negative type of coping include things like substance abuse and denial. There are some relaxation strategies that we can do and teach our patients to help combat stress. The relaxation response is a state of physiological and psychological deep rest that is characterized by a decrease in our sympathetic nervous system activity. This means that our heart rate will drop, our blood pressure will lower, our respirations will slow down, we won't have as much muscle tension, and it'll decrease our brain activity as well. Some relaxation strategies that we can do are things like relaxation breathing, meditation, imagery, music for relaxation, and massage. To teach relaxation breathing, you want to begin by placing one hand gently on your abdomen, below your waistline, and place the other hand on the center of the chest of the sternum. Without changing the normal breathing pattern, just take several breaths. During inhalation, we notice that the hand rises the most. Which hand rises the most? When relaxation breathing is performed, the hand on the abdomen should rise more than the hand on the chest. This means that you are not taking in quite as deep breaths and your breathing is becoming more relaxed and shallow. With meditation, there are several positive health benefits to meditation. Things such as reversal of coronary heart disease, decreased cholesterol, and even an increase in our immune functions. Guided imagery is the use of one's mind to generate images that have a calming effect on the body. Benefits of imagery include anxiety reduction, decreased muscle tension, improved comfort during medical procedures. There are some alternative therapies that we can also educate patients on to help battle with stress. Ginseng is very good for enhancing mental performance. It can lower blood glucose, but it's important to remember that it can reduce the effect of warfarin. St. John's wort is another alternative therapy that's been known to improve symptoms of depression. However, it's important to remember that if the patient is truly depressed, that they may need to seek medical attention and not self-medicate with over-the-counter medications such as St. John's wort. It's also important to remember that with St. John's wort, it can interact with antidepressants as well as warfarin as well. Exercise is a very good alternative therapy because it improves mental and physical well-being. It's been known to improve several conditions, not only with anxiety or stress, but to also help with things like hypertension, heart disease, and depression. When assessing a patient for signs and symptoms of stress, We not just want to focus on physical, but we want to look at behavioral and cognitive symptoms as well. Patients with physical symptoms may have things like an increased heart rate and blood pressure. They may have hyperventilation, which is an increase in their respiratory rate. They may complain of pain, such as headaches. More behavioral symptoms are things like anxiety, irritability, or impaired speech. And at the cognitive level, the patient may report that they have a lot of forgetfulness, or they're unable to decide things such as procedures and treatment options. It's important for the nurse to be aware of situations that are likely to result in stress. We want to assess the patient's perception of the situation and identify coping mechanisms that we may use to help hit it off head on. All right, pain is in the brain, right? Pain is a major reason that people seek health care. Nurses have a central role in assessing and managing pain in our patients. In the United States, about 25 million people experience acute pain as a result of injury or surgery. Chronic pain from arthritis, migraine headaches, and back pain affect approximately 116 million adults. Despite being a technological and advanced society, most acute and chronic pain is inadequately managed. Pain can be a complex, multidimensional experience that causes suffering, reduces the quality of life. It's the primary reason that people seek health care. It typically goes undertreated because we do not go with pain as what the patient says. We think that we should be able to find a reason that they are in pain. Pain is also associated with longer hospital stays, longer recovery times, and poorer patient outcomes. All right, let's talk about the magnitude of the pain problem. In the United States, 25 million people experience acute pain from injuries and surgeries each year. 560 to 635 billion dollars were spent on inadequate pain management per year. Families state that over 24% of dying people did not get adequate pain relief during their last days. Undertreatment of pain causes unnecessary suffering, physical and psychological dysfunction, impaired recovery from acute illness and surgery, immunosuppression, and sleep disturbances. And let's think about this in a different way. If we are not adequately managing pain in a post-surgery patient, how are they going to recover faster by doing the things we need them to do, such as participating in physical therapy, getting up and walking, doing their activities of daily living? Management of pain goes hand in hand with taking full holistic care of our patients. So how do we define pain? Pain is a conscious perception that results from environmental stress. The perception of pain involves both peripheral and central nervous systems. It can be activated at any point along the nerve pathway. It is a multidimensional phenomenon, so it's very difficult to define. It can be defined as feelings of agony, distress, and suffering, usually related to some type of tissue damage, which acts as a warning signal. This warning signal warns us about potential physical harm and prevents further damage. The nursing definition for pain is whatever the person experiencing the pain says it is, existing whenever the patient says it does. All right. Pain is very subjective and a very personal experience. What one person's pain level might be for an injury may be completely different than what another person's pain level might be for the same injury. No two people experience pain in the same manner. Each person is the expert about his or her own pain. The only person who can accurately describe their pain is the person experiencing it. I want you to remember that all pain is real. Just because you might not be able to physiologically see a patient should be in pain does not mean that they're not experiencing pain. For instance, let's think about neuropathy pain. Neuropathy pain in diabetics is very real, even though you can't see any reason why they should be in pain. Patients that have bilateral, or maybe they've just had an amputation, all right, they're talking about having phantom pain. Just because that bottom part of their leg is no longer there doesn't mean that they are not truly experiencing pain. All right. Pain can be influenced by gender, culture and ethnical backgrounds, and age. So it's important to remember that elderly may have higher pain tolerances than younger people. Men might have less pain tolerances than women. Different cultures have different ideas about pain and what methods they want to use to treat their pain. Some are not really big on using a lot of medications to treat pain. They want to use a lot of alternative therapies. So it's important to remember those things when we're looking at options of treating pain. There are 5 dimensions of pain. Sensory is known as the perception of pain. Physiological is the transmission of a nociceptive stimuli. It's an anatomic and physical determinants of pain influence how painful stimuli is processed, recognized, and described. Affective is the emotional response to pain experience, such as anger, fear, depression, or anxiety. Cognitive discusses about beliefs, attitudes, memories, and meaning attributed to pain. Behavioral is observational actions used to express or control the pain, such as facial expressions. Patient might be socially withdrawn, use of relaxation techniques, or taking medications for pain. Let's talk about some gender differences when we're looking at treating patients with pain. Men versus women, right? Men are less likely to report pain, whereas women are more likely to experience more chronic pain. Men are more likely to report more control over pain, whereas women are more likely to report things like headaches, back pain, arthritis, and foot aches. And men are also less likely to use alternative treatments for pain, whereas women are more likely to identify stress as a cause of pain. All right, the pathophysiology of pain involves 4 processes: the transduction, transmission, and perception modulation of pain. In the transduction phase, it occurs where there is a release of chemical mediators. Transmission involves the conduct of the action potential form to the periphery or the injury site, to the spinal cord, and then to the brainstem, to the thalamus and cerebral cortex. Perception is the conscious awareness of pain, and modulation involves signals from the brain going back down the spinal cord to modify incoming impulses. There are 3 types of nociceptive pain: superficial somatic, deep somatic, and visceral. With superficial somatic, this arises from the skin membranes and subcutaneous tissues. It's described as a deep, aching, or burning pain. Deep somatic pain comes from our bones, joints, muscles, or connective tissues, and patients may describe it as a deep, aching, or throbbing pain. And visceral pain arises from internal organs, such as our bowels, stomach, bladder. It's usually related to some form of inflammation, stretching, or ischemia. And it has referred pain, where usually a source may be distant from the location of the pain reported. Neuropathic pain is the damage to the peripheral nerve or the central nervous system. Patients may complain of numbing, hot burning, shooting or stabbing, or even electrical in nature type pain. It can be sudden and intense. It can be short-lived or lingering. Some common causes of neuropathic pain are trauma, inflammation, metabolic diseases like diabetes, infections of the nervous system such as herpes zoster and HIV, tumors, toxins, and even neurological diseases such as multiple sclerosis. It's not often well controlled by opioid analgesics alone, so we can use some augmented adjunct therapies such as tricyclic antidepressants, SSRIs, anti-seizure drugs like gabapentin, that's a very common one, or even alpha-2 adrenergic agonists such as clonidine. More recently, we started using things like ketamine that is shown to be pretty promising in alleviating neuropathic pain refractory to other classes of the anti-neuropathic pain drugs. Complex regional pain syndrome, it can cause very dramatic changes in color and temperature of the skin over the affected limb or body. It can be an intense burning pain, may be really sensitive to the skin, and your patients may even have some sweating and swelling to go with this. Acute pain is caused by the activation of nociceptors or pain receptors, maybe something like an incisional pain after surgery. Usually has a short duration, less than 3 months or as long as it takes for the normal healing to occur. It can be very sudden, immediate, with a very rapid onset. It can range from mild to severe. Maybe accompanied by some physiological responses such as their blood pressure goes up, their heart rate's elevated, increased respirations. Your patient may be looking anxious or agitated. They may have diaphoresis or pale. They may be confused. Some patients even have urinary retention. Patients may be more focusing on the painful area, or you may see them guarding. Usually guarding is pretty common with abdominal pain. When the pain is relieved, the person will generally return to the pre-pain normal state. Acute pain can typically be treated with analgesics as long as we're treating the underlying cause. And acute pain, if untreated, can become chronic pain. Okay, let's talk about the effects if acute pain goes unrelieved. All right. Our body has some physiological responses that are going to kick in with this. So from the endocrine and the metabolic standpoint, we're going to have increased cortisol levels. We're going to have decreased insulin, meaning that we're going to probably have an elevated blood glucose issue. Cardiovascular system is going to kind of work in overdrive. It's going to increase our heart rate. We're going to have an increase in peripheral vascular resistance, and our body's demand for our myocardial O2 consumption is going to go up. So it's going to put a little bit more stress on our heart. With our respiratory system, with us having such elevated, if we have a lot of increased respirations, we're going to experience some hypoxemia. Remember, rapid labor breathing, they're not breathing in near as much oxygen or tidal volume as they need to be able to oxygenate the body. Our gastric system is going to have some decrease in gastric motility. Our muscular system, we may have some muscle spasms, especially that's going to go hand in hand with that elevated rapid breathing, because we're going to be blowing off a whole lot of CO2, which can cause us to have some muscle spasms. Neurologically, we can have impaired cognitive function. Your patient may be confused, lethargic, anxious, and it's going to also decrease our body's immune response. Chronic pain may have started as acute pain, but continue past the normal recovery time, lasting more than 3 months. It can be disabling and is accompanied by anxiety and depression. It can range from mild to severe with no really foreseeable conclusion. It can be localized to one area or widespread. The cause of chronic pain is often unknown, unless it is more of a chronic pain with acute exacerbation for diseases such as migraines, sickle cell, irritable bowel syndrome, cancer-related type pains. Patients who complain of chronic pain are often complaining of things such as fatigue, sleep disturbances, or limited functions. Patients with chronic pain may be more sensitive to other pain and stimuli, and we have to remember that without managing chronic pain, it affects the quality of life of our patients. Managing clients with chronic pain can be challenging. They may present with symptoms of depression, insomnia, and limited functioning. They may adapt what are known as pain behaviors and the sick role in order to gain more compassion than treatment from healthcare providers. They may voice frustration with the healthcare system as they search for the specific cause of their pain and one definitive treatment. They're going to go through this chronic pain cycle of having pain, fear of injury, fear of movement. Then they result in less movement. Then they get into a deconditioning or disuse syndrome, means they completely just stop doing things altogether, where they reach the physical and mental deconditioning syndrome, where then they just really quit doing everything altogether. So what are some signs of pain that we might see when we're assessing our patients? They may have a very guarded, protective behavior. They may have hands over their painful area or a very distorted posture. They may seem irritable. Think about how you feel when you're in pain. Does that increase your irritability level? Certainly. They may have a facial mask of pain, a very distorted expression. They may have some vocalization such as groaning, crying, or a very talkative patient would then become quiet. They may have some body movements such as head rocking, pacing, inability to keep their hands still. Some physiological symptoms you might see is a change in their vital signs. So what would be some vital sign issues? They may have an elevated heart rate, blood pressure might go up, respirations will increase. They may become pale and diaphoretic. Their pupils may become dilated, and they may have a decreased attention span or seem to have some greater confusion and can't concentrate. It's important for nurses to remember that patients have the right to appropriate assessment and management of pain. Pain is always subjective. You may not see any objective signs of pain, so pain is subjective. It is what the patient says it is. You may see some physiological and behavioral signs, such as tachycardia and grimacing, but they're not always a reliable source or specific to the pain. We need to remember that pain is an unpleasant and emotional experience, so our assessment approaches need to be appropriate for the patient population. Pain also exists when there's no physical cause that can be found, so it's important for nurses to remember that pain is what the patient says it is. We also need to keep in mind that different patients experience different levels of pain in response to a similar stimuli. So one patient that is post-op gallbladder surgery may have a different pain level than another patient that is post-op gallbladder surgery. Everybody has a different tolerance level. Patients with chronic pain may be a little bit more sensitive to pain and other stimuli in acute situations. Unrelieved pain can have adverse consequences. We talked about that with chronic pain issues. And acute pain that is not adequately controlled can result in physiological changes that increase the likelihood of developing a persistent level of pain. Nurses should assess pain in all patients. There is not a uniform pain threshold to exist. Patients' self-report of pain is the single most reliable indicator of pain, and typically we like to use the 1 to 10 pain scale. Remember, meaning that 1 is the least amount of pain or no pain, and I always tell patients that 10 is the worst pain they have ever experienced thus far in their life, because the patient may be thinking, well, 10 is worst. Well, I haven't really had anything bad happen, so yeah, this sounds like a 10, right? Versus that if a woman is in labor, has had a child, she's going to probably relate child labor as that 10 worst pain. So she may give you a different number because she remembers what that high level of pain is. It's important that we accept and respect the patient's level of pain unless there are clear reasons to doubt it. We do not rely primarily on observations or objective signs of pain unless the patient is unable to self-report. And you're going to learn next semester when we start talking about critical care, what are some signs and symptoms that you can assess for pain in the patient that is either sedated or unconscious in the critical care setting. We need to remember to address both physical and psychological aspects of pain when assessing a patient's pain. There may be some special considerations needed for assessing pain in patients with difficulty communicating, such as including family members in the process. A patient that is maybe post-CVA and they are have slurred speech or they're unable to communicate. That would be a good time to ask for family members to kind of help, because family members know how their loved one acts on a normal basis compared to when they may be in a painful situation. Pain tolerance varies among and with individual individuals depending on various factors such as hereditary, energy levels, coping skills, or maybe even prior experience with pain. Patients that have chronic pain that are in for an acute exacerbation such as sickle cell, they kind of know how their pain tolerance normally is going to be and things that generally tend to help treat the pain. We want to encourage our patients to report pain, especially in patients who are reluctant to discuss pain or who may deny pain when it's probably present, or who may even fail to follow through on some of the prescribed treatments. We must always use the best scale available for the patient. Some patients will need help to understand the scale, so we need to explain it to them in detail. Some cannot use a 1 to 10 pain scale very well, but they can maybe respond by using the face or the word scale. We want to be sure your patient understands what you are asking before you decide that you have done a good job. And if the patient is hurting but doesn't understand the scale, they may not receive the medication they need, so be sure before you assume anything. Sometimes this particular scale is easier for the patient to use. They can point to a particular face or word, especially if they are hearing impaired. Scales such as the faces would not work for someone who is sight impaired. You are responsible for making them understand what you are asking, and you must take the time to be sure that they can give you the correct answer for your pain scale questions. The good thing about this scale is that it incorporates the faces with words with numbers. So it's kind of available to use for any type of patient. You're going to learn more about the use of the FLAC scale next semester when you get into the critical care portion, because this is very commonly used in patients that are non-communicative, such as they're unresponsive or they're sedated on ventilators in the critical care units. It's also important to remember that the FLAC scale is also good to use in infants or young children who are still not able to speak or understand what you're saying to them yet. As nurses, all patients should be screened for pain, right? Current level of pain should be assessed with every set of vital signs. Pain is the 5th vital sign. If pain is present, then a pain history should be completed. We need to do a reassessment of a pain level after we've done some form of an intervention, like administering a pain medication. If you gave an IV medication, we need to reassess the patient within 5 to 15 minutes. And if we gave an oral medication or even an IM injection, we need to assess the patient within 30 minutes to 1 hour. Making sure you reassess the patient after a medication is given is a critical part of pain management. It is an expectation for everyone who administers pain meds to reassess the pain because it's a national safety goal and we must be done to be compliant. We should do it because it's the right thing to do, not just because it is a policy from a regulatory agency. Pain is a required assessment and treatment in the eyes of some of our accreditors. I'm sure that some of you that are working out in the healthcare systems have come in contact with what's known as JCAHO, the Joint Commission on Accreditation of Healthcare Organizations. And they really set forth some patient safety goals to help us improve the quality of care of patients. They are very big on pain. They say that pain needs to be assessed and recorded for all patients. Patients be asked upon admission if they have pain or a persistent pain problem. We're going to see about doing a repeated assessment whether or not there was an initial complaint. So every time you go in the room and you assess your patient or you're completing a task or you're taking vital signs, we need to ask the patient, are you experiencing any pain? Joint Commission requires prompt treatment of reported pain to be assured, and that the intensity of pain be repeatedly recorded to follow its course and validate relief. So if you went into the room and you asked your patient and you said on a pain scale of 1 to 10, are you experiencing any pain? And the patient says, yes, I have a pain of 8. And you go back and you look at the order and you see that they have some medication ordered and you go back and you treat it, it is your responsibility to go back and perform a reassessment. Because if you went back and reassessed the patient and they said, well, now my pain's a 5, you go, well, that kind of what I did helped a little bit, so now let me see what my other options might be. We do not need to go with the idea of, well, I treated it once and they're just going to have to wait until the next time around. We need to constantly be reevaluating the patient for pain. Patients may come to the hospital when pain is the chief complaint. The one that typically comes to my mind is usually abdominal pain. That's a very common one where patients will present to the ER and you ask them, why are you here? And they say abdominal pain. Okay. It's important to remember that the location and related symptoms may assist in the diagnosis of a patient's condition. So if they're complaining of abdominal pain, I need to assess, well, what part of this abdomen is hurting? What does it feel like? When did it start? Does it radiate anywhere? Because then that's going to help me kind of come around to what may possibly be wrong with this patient. When related to a diagnosed condition, assessment of the character and intensity of the pain is necessary for control. So for instance, patients that are coming in with pancreatitis, they're going to come in complaining of a very different type of abdominal pain. They may say it may be mid-abdomen, it may be sharp and stabbing. They may have nausea and vomiting to go with it. So then if I can control this pain, then I may be, that's the idea to maybe the part of the treatment of the pancreatitis. Okay, it's important to remember that there may be more than one cause of pain simultaneously. So it may be multiple things that are causing pain, and we just have to start kind of treating them and isolating out what it may be. So when we start assessing a patient for pain, we're going to look at some things like the pain pattern, the location, the intensity, and the quality. Underneath the pain pattern, I want to know when the onset was, how long the duration has been, and any breakthrough. Onset will tell you, acute will be very specific, but a chronic patient may not be able to tell you when it started. They may tell you it's been going on for several months. The duration part is how long it has lasted. This will help you determine if it's an acute or a chronic problem, or if it's a constant or an intermittent issue. For instance, if a patient came in with complaining of abdominal pain, and you asked them, well, how long has it been going on? Is it constant or intermittent? And they said, well, it's not constant, but it only occurs when after I eat, so it kind of comes and goes. Well, that's going to change your thought process on what might be causing this pain. Breakthrough pain is very transient. It may be moderate to severe and can occur in patients whose pain is otherwise usually controlled. All right, so usually like a breakthrough pain is usually associated with the cancer patient. All right. Location, all right, this is what we want to ask the patient, where is it hurting? A lot of times we want them to point to the specific area or tell you exactly where it is. That will kind of help us, especially with things like abdominal pain, because then I have to think about what organs are where and what might be the potential issue. If it radiates, I need to know, what is radiation? Radiation means, well, does this pain go from one spot to the other? Or we can even ask about referred pain. Do you hurt anywhere else? A lot of times when the peritoneum and the abdomen is irritated, they're going to complain of shoulder pain as well. Or they may complain of some things where they say, well, this pain starts in my abdomen and it shoots into my back, things like that. We want to talk about the intensity. Utilize the pain scale, the 1 to 10 pain scale if possible, to assess the patient's pain level. And then, of course, quality. Ask them to describe in their own words. A lot of times I give them some options because they may not exactly know what they're looking at. So I may say, if they can't come up with the words, I say, does it feel sharp, shooting, crushing, aching, dull, cramping, tearing, things along that line. Try to identify the quality. If you can identify the quality, it's going to also help me kind of figure out. So just like chest pain, if a patient is complaining of chest pain that is sharp, my mind is going to go to something different than if their chest pain is complaining of feeling like a heavy pressure. Okay, so quality really plays a significant role. When doing a pain assessment on a patient, we want to look at associated symptoms. Things like, is your patient experiencing anxiety? Do they seem to be fatigued? Depression is very common in chronic pain. You may ask your patient, what makes it worse? What makes it better? We want to look at management strategies. We want to ask them, what do they do to decrease or eliminate the pain? We want to know about the impact of pain on their quality of life. How does it affect their sleep, their life enjoyment, their social life, their work and household duties? We want to know what their patient expectations and goals are. These influence the way people react to pain, and some may hinder your ability to help them, such as a patient fear of addiction. How many times have you had a patient that would say, well, I would rather take the Tylenol and I don't want to take the hydrocodone because I don't want to get addicted to it? Okay. We need to look at some painful behaviors such as grimacing, crying, moaning. They may be guarding, especially in abdominal pain. They may seem real restless or tense. They may even be silent or withdrawn from people. The presence of pain behaviors is not a reliable indicator of the quality or the intensity of pain, but absence of nonverbal behaviors does not mean the patient is not in pain. It's important to remember that every patient deserves adequate pain management. Treatment should be based on patient's goals. The nurse needs to develop realistic goals with the patient and reassess periodically to see where we're at with that. Some things we can do, we can use drug and non-drug therapies combined together. We can use a multi-model approach to analgesic therapy. This means that 2 or more classes of analgesics. This is why sometimes it's really good to give things like hydrocodone and ibuprofen or some form of NSAID, 2 different types of classifications of drugs. We can do a multidisciplinary approach where we not only use medications, but we might add in physical therapy, occupational therapy, massage, even surgery sometimes is an option to treating acute or chronic pain issues. We want to evaluate the effectiveness of our pain management. We want to try to prevent or manage side effects. This is really important. So we need to be thinking about what are the issues that may come with treating patients. So patients that are on a morphine PCA pump, we may be thinking, well, opiates, one of the big side effects with opiates is it kind of slows things down. So they're at high risk for constipation. Well, how can we address constipation? Increasing the amount of water they drink, or maybe giving them a stool softener or laxative daily. So we want to try to manage side effects that are going to come with this. We want to involve the patient and family in teaching throughout the assessment and the treatment. We're going to get a little bit more better goals met if everybody is on board with the same thing. Let's look at some pain management strategies. Balanced analgesia. What is balanced analgesia? It's the use of 2 or more analgesics simultaneously, such as codeine with acetaminophen. It provides more pain relief with maybe a little bit less side effects. PRN means as needed. So it means to medicate only when the patient reports pain. It's not the best approach to pain management because it takes longer to get pain under control when it's already present. The preventative approach means that medications are administered at scheduled intervals, reduces peaks and troughs in the serum opioid levels, and provides more stable pain relief. So an example of this might be if a patient's coming out of surgery, they may have a continuous epidural pump going, and the idea with that is that we can manage their pain continuously so that they can be active in some of their rehabilitation needs to be able to recover quicker. Individualized dosing. This means that a patient requires different amounts of pain medications to control pain. What works for one patient won't necessarily work for the other. And we always assess the patient following medication administration. And we may need to talk with the doctor about medication dosage changes as needed. All right, we're going to talk about 3 types of analgesics: opioids, non-opioids, and some other adjuvant agents that we can use to control pain. Non-opioids are generally the first class of drugs used for treatment of pain. They work peripherally, whereas opioids work centrally in the brain and the spinal cord. They're very useful for acute and chronic pain from a variety of causes such as surgery, trauma, arthritis, and cancer. It's important to monitor over-the-counter analgesics used to avoid serious problems related to drug interactions, side effects, and overdoses. They are often used in conjunction with opioids because they allow for effective pain relief with lower opioid doses, thus causing fewer opioid side effects. This is called the opioid sparing effect. They do have a ceiling effect to analgesia, meaning that there's a maximum effective dose. Increasing the dose after the max does not increase pain relief, but may increase side effects. So for instance, if you have already taken 1,000 milligrams of Tylenol, taking 1,000 milligrams of Tylenol 30 minutes later is not going to help with the pain relief, but work more on increasing the side effects. Non-opioids are effective for mild to moderate pain. They do not produce a tolerance or an addiction. Many of these are over the counter, and a lot of them have anti-inflammatory effects, such as ibuprofen, naproxen, naproxen. They block the production of prostaglandins, except for acetaminophen does not, thus decreasing pain by sensitizing the chemicals. Aspirin and other salicylates are very good for treating mild pain. But it's important to remember that the use needs to be limited because of its common side effects. Side effects such as increasing risk for GI bleeding, platelet dysfunction, other forms of bleeding, as well as it's very much an irritant on the GI system. Acetaminophen, known as Tylenol, does not have any antiplatelet or anti-inflammatory effects. It's well tolerated, but is metabolized by the liver. So it's important to remember that chronic dosing, acute overdose, or even use by patients with severe pre-existing liver disease can result in hepatotoxicity. Acetaminophen provides a multi-modal therapy. This is the reason that they do a lot of combination of an opioid with acetaminophen, such as oxycodone or hydrocodone combined with acetaminophen. It is a drug of choice for patients with pain who have viral infections. NSAIDs represent a broad class of drugs with varying efficacy and side effects. They're effective for mild to moderate pain in non-arthritic patients. They're very good for cancer patients because they can potentiate the effects of opiates. So you may see a lot of ibuprofen, naproxen, or naproxen given with hydrocodone or oxycodone. They're very effective for bone pain, such as bone metastasis of malignancy or fractures. And NSAIDs have been linked to a higher risk for an increase of cardiovascular events, such as myocardial infarction, stroke, and heart failure. Opioids are commonly used for moderate to severe pain treatment. They inhibit the transmission of the nociceptive input from the periphery to the spinal cord, alter the limbic system activity, and activation of the descending inhibitory pathways that modulate transmission into the spinal cord. They're derived from a natural opium alkaloids as well as their synthetic derivatives, and effects are similar to those of opium. They can be categorized from weak to strong. They're used for moderate to severe pain when non-opioids are not working. And all opioids have side effects, so we can try a different med if side effects of one are not tolerable from another. Opioid agonists are derivatives that bring about pain relief by producing maximum degree of receptor binding. Some examples of these are hydrocodone, codeine, meperidine, known as Demerol, hydromorphone, and methadone. They are effective for treating moderate to severe pain because they are very potent, they have no analgesic ceiling effect, and they can be administered through several routes. It's common that we use opioid agonists with non-opioid analgesic for relief of moderate pain. Methadone is a potent, long-acting opioid analgesic. It has a long plasma life, which makes it necessary for these patients to be monitored more closely. With repeated doses, it can develop a cumulative effect over a 1 to 2 week period. Some indications we may give this medication is to treat severe pain or to suppress withdrawal symptoms in people that are coming in for opioid addiction treatments, known as detoxification. If we're treating it for the analgesia effect for pain, we normally may give 20 milligrams every 6 to 8 hours. If we are trying to treat a patient for opioid detoxification, then we're going to up that dose to up to 45 milligrams or the amount needed to prevent a withdrawal in these patients. Opioid agonist-antagonists engage one receptor while inhibiting a receptor binding with another. When given with following the prolonged use of opioids, we have to be very careful that these medications can suddenly reverse the medication effects and precipitate an acute withdrawal. Examples of these medications are things like Nubain, Stadol, Buprex. When it's given alone, it does produce a good pain relief with fewer side effects than opioids. So it's very important for nurses to get a good medication history before we administer any of these medications. If a patient has been chronically taking an opioid such as methadone, hydrocodone, oxycodone, we want to advise the physician that we do not need to give these medications to this patient because it will throw them into a withdrawal. Constipation is a common side effect of an opioid analgesic. It is not a reason to discontinue this medication because we can do some prophylactic treatments such as high fiber diet with adequate fluid intake or administering stool softeners or a senna-based medication with it. Nausea and vomiting, we may need to change the type of opioid, especially if patients are having a hard time getting this under control. This side effect is usually decreased with use. So it's a very good practice that when we administer an opioid that we give an antiemetic with it. So for instance, if you were giving a patient some hydrocodone, you may also take them some Zofran or some Phenergan in there with it. You also may ask about having them eat something small, like some crackers, or something that may not quite upset the stomach, but will help kind of take the effect with it. Nausea and vomiting should not be the big reason that you deny pain relief in our patients. They still need to be treated with pain. We need to treat the side effects that go with it. Cutaneous effects may facilitate a histamine release, resulting in pruritus, which is itching, flushing, or even sweating. So we can treat this with an antihistamine, such as Benadryl is a very common one. We need to keep in mind that these occur most frequently when opioids are administered via neuraxal, such as epidural or intrathecal routes. Urinary retention is another side effect caused by an increase in muscle tone of the detrusor muscle of the bladder and the bladder sphincter. This hypertone resists opening and prevent adequate bladder emptying. So we may need to look at inserting a catheter if the patient is unable to urinate and having an increase in urinary retention. All opioids have the potential to cause respiratory depression. It is not usually dose related, and this is why it is so important to assess and reassess the patient each time we give an opioid med. Part of the assessment needs to be the sedation assessment scale. Normal sleep we expect. We're okay if your patient is in that 1 through 4 range where they can be anxious to calm to drowsy to even asleep, but they will respond to some verbal stimuli. Once they reach that 5 or 6 on the scale where they're very sluggish or they're unresponsive, the nurse needs to be concerned that we now have an airway problem. Some other things that you might see in your assessment findings that go with sedation and respiratory depression are things like they may have a low pulse ox. Okay, a lot of this is going to go hand in hand with them not breathing as deep or as normal as they need to be. They have that sedation level of 5 or 6. They may be hypotensive. Their pupils may seem pinpoint, and their respiratory rate may be less than 8. These are all indicators that we have got an issue with respiratory depression and that they're unable to protect their airway. So, first thing you want to do as a nurse is you want to assess your patient, right? You need to assess, you need to do a neuroassessment, a quick neuroassessment, and you need to do the quick set of vital signs. And then you need to try to arouse your patient, all right? Whether that's a little bit of a sternal tap or a tap on the forehead, see if they'll respond to any kind of stimuli. If they do not, Narcan is the antidote for opioid analgesics, so we can administer some Narcan that can be given IV or IM. That will help establish the airway because it should arouse and reverse the medication and wake the patient up. If that is not able to do so, then we may have to look at intubating this patient and putting them on the ventilator if necessary. Narcan is an opioid antagonist, meaning it is a reversal agent for opioid agonists. It reverses the side effects and the analgesia options of the opioids. So it will be used in cases of respiratory depression, patient is over-sedated, or your patient is unresponsive. It can be given IV or IM. We don't really no longer want to use it more sub-Q. It's more effective with the IV or the IM route. Dosaging for narcotic overdose is anywhere from 0.4 milligrams up to 2 milligrams. Dose for a post-op patient where narcotic depression is 0.1 to 0.2 milligrams. And it's usually given in repeated doses until the desired effect. You should see this pretty quickly, especially if it's given IV. It's got an onset of 1 to 2 minutes. So you're going to know within a few minutes of giving it if this is going to work how you need it to work. We need to remember that if a patient has been taking opioids pretty regularly for more than a few days, that the naloxone or the Narcan should be used judiciously because we can precipitate severe agonizing profound withdrawal symptoms, and we can even decrease their seizure threshold and cause them to have seizures. Because Narcan's half-life is shorter than most of the opiates, we want to make sure that we monitor the patient's respiratory rate. It can drop again in 1 to 2 hours. So you may give a dose to your patient and 5 minutes later they seem fine, but you come back an hour later and the Narcan is no longer working and they're back to being over sedated again. So adjunct medications were developed for other uses, but have been found to have pain relieving properties. They may be used in combination with other analgesics or alone. They can be given daily at bedtime, so the accompanying drowsiness kind of helps your patient with sleep. Antidepressants, such as tricyclic antidepressants, Effexor, Wellbutrin, and Cymbalta, they increase the serotonin and norepinephrine, which results in the inhibition of pain signals. They appear to be effective in a variety of pain syndromes, especially in neuropathic pain syndromes. Anti-anxiety medications such as Valium and Xanax help decrease the receptiveness to incoming painful stimuli. Anticonvulsants, such as Neurontin and Lyrica, help with neuropathic pain. Corticosteroids, dexamethasone and prednisone, they decrease edema and inflammation. They're used for the management of acute and chronic cancer pain, pain secondary to spinal cord compression, and inflammatory joint syndromes. They may also decrease activation of an inflamed neuron, so it's useful when injecting epidurals for acute or subacute disc herniations. GABA receptor agonists, they reduce muscle spasms. A common one is baclofen, by interfering with the transmission of nociceptive impulses and is mainly used for treating muscle spasms. It crosses the blood-brain barrier poorly and is more effective for spasticity when delivered intrathecally. You might see some local anesthetic agents used to treat pain because they can cause a loss of feeling in a restricted area. Some common medications you might see will be lidocaine and bupivacaine. These can be applied topically or infiltrated into an area. Lidocaine is short-acting. It works within about 5 to 15 minutes, and it can last up to 2 hours. It's one of the most commonly used local anesthetic drugs. Bupivacaine is a little more long-acting. It will last from 4 to 8 hours, but it has a very slow onset. It is 4 times more potent than lidocaine and 4 to 6 times more toxic. So we use a lower concentration of it. Bupivacaine is sometimes injected or infused into an incision after surgery for post-op relief. EMLA cream must be applied at least 45 minutes to 1 hour before the procedure and covered with an occlusive dressing. It's commonly used in the nursery setting prior to a circumcision. Nerve blocks are permanent nerve blocks that may be used to relieve cancer-related pain. They block sensory and motor conduction of a nerve, and it can be temporary or it can be irreversible. When managing pain in a patient, scheduling is an important aspect for nurses to focus on. We need to focus on prevention and control of pain. We do not want to wait for pain to become so severe that it becomes difficult to manage. We want to schedule medications to control constant pain that requires around-the-clock administration and not necessarily PRN. PRN can be very hard to manage because with PRN, we wait for the patient to tell us that they have reached a level of pain that they would like medication, and it makes it a little bit more challenging for us to keep it under control. We need to think about using fast-acting drugs for breakthrough pain, such as things IV that are going to have a quicker onset. They may not last as long. And then we might need to follow through with that with maybe an oral medication that won't have quite the quick onset, but will have a little bit longer duration to it. Titration, we want to use the lowest dose possible for pain control. Dose adjusted based on the effect of the analgesic versus side effects. Acute pain dose usually is titrated down as pain resolves. With chronic pain, the dose is usually titrated up to maintain pain control. Our goal is to use the lowest dose possible with the least amount of side effects. Equianalgesic dosing. This is the dose of one analgesic is equivalent to the dose of another. So we can substitute one analgesic if side effects occur with another, such as using Loratab instead of Darvocet. are several routes of medication administration that nurses can use to administer pain medications. The oral route is the most common route of choice with a patient that has a functioning GI tract. This is because most pain meds are available in oral preparations such as a liquid and tablet. The concern is for opioids, we have to give larger oral doses needed to achieve the same equivalent analgesic dose as an IM or an IV dose. So for example, 10 milligrams of morphine given IV may equal to 30 milligrams of morphine given PO. The reason is larger doses are required because of the first pass effect of hepatic metabolism. Sublingual and buccal, these can be administered under the tongue or held in the mouth. They are exempt from the first pass effect. Transmucosal, such as a fentanyl lollipop or given sublingually, is very good for pain relief. It kind of has an onset of about 5 to 7 minutes. Intranasal is exempt from the first pass effect. Stadol is actually one of the few medications that we can currently give through an intranasal spray. Rectally is useful for patients who cannot tolerate PO medications such as from nausea and vomiting. One thing to note though is that there are a lot of PO formulations that we can give in rectally if a suppository isn't available. So there are very few exceptions to this rule, but a lot of your tablet medications you would normally give PO can be given rectally as is. Transdermal, it's effective for stable pain control. One of the most common transdermal patches we use is known as the fentanyl patch or Duragesic. It delivers a specific amount of medication over a 48 to 72 hour period, but it's important to remember that the absorption is slow. So when you put a patch on, it may take 12 to 17 hours to reach the full effect with the first application. It's important to remember that we want to remove the old patch before applying a new patch, and we want to apply the patch to a non-hairy skin area. We can use some topical creams like Aspirin or Milaflex to help with joint and muscle pain. This aspirin-like substance is absorbed locally. It's a good route because it avoids the GI irritation usually associated with salicylates, but other side effects of high-dose salicylate aren't prevented. Parenteral routes such as sub-Q, IM, and IV are another choice that we can give IV pain medications through. Single, repeated, or continuous dosing is possible, but remember continuous IV is the best route for immediate analgesia and rapid titration. It provides a steady state of analgesia. While an IM route takes a little bit longer for onset, it does seem to have a longer duration effect. One common method of pain medication administration that you're going to probably see in the acute care setting at the hospital is the use of a patient-controlled analgesic known as the PCA pump. The PCA pump allows them to administer medication via IV, usually a peripheral IV, or it can be sub-Q through things like an epidural. The concept is that the patient can self-administer their dose by pressing a button that releases a preset amount of medication. The pump releases the preset doses until the preset demand limit known as the lockout is reached. So what this means is that the patient may have ordered 1 milligram of morphine every 15 minutes with a maximum of 4 milligrams an hour. So the patient pushes the button, it gives them 1 milligram of morphine. Well, they can push that button all day long, but it's not going to give them another dose until it has reached that minute minimum period of time, so that 15 minutes, whatever it's set at. And then once it reaches the total maximum for the hour, it will not let them have any more until the new part starts over. You may see some patients that have a continuous dose. This concept comes from where some patients would complain that they might awaken in the night in pain and have to redose themselves several times to get back to an acceptable level. So some pumps are set to give a small amount of continuous medication to avoid this. The patient then administers the medication only when it isn't enough during like a PRN interval. This is also a very common practice that you'll see with like post-surgery patients. By giving a patient a continuous dose, it's much easier to control pain to where they can participate in their activities of daily living or their therapy to help improve their rehabilitation. If this is not working, then we may need to change to another pain medication or another option of administration. Some advantages to using the PCA pump is that patients usually report good pain control. Kind of helps reduce their anxiety level about waiting for the nurse to get there to administer their pain. We all know that sometimes that we can't get to them as soon as we would like to. It promotes independence and control of their pain. Patients can administer small dosage of opioids than with other methods. They can adjust medication to a near constant concentration in the blood. Patients will report some superior analgesia with lower dosages. And as the pain lessens, patients tend to adjust to lower doses by titrating this pump down and eventually stopping it. It is important to remember that according to Baptist Health policy, only a patient can administer pain medications through the PCA pump. Other methods to administration of pain medications include things like the intraspinal or epidural route. This is where local anesthetics are combined with opioids. This is usually placed in patients that are coming out of the OR or are going into the OR. Labor and delivery will also be another common place that you're going to see these. These are usually placed by the anesthesiologist or the CRNA. It's important to remember that there's some side effects that may come with these, such as pruritus. Patients may complain of itching, urinary retention, so we need to monitor for urinary output, and delayed respiratory depression. Respiratory depression can occur 6 to 12 hours after administration. Some hospital facilities will require a continuous pulse ox monitoring. If it's not required, then we need to do it more frequently than we normally would. The lumbar is the most common site for epidural, but it can be placed higher. We need to remember there's some complications that can occur with this, such as catheter displacement or migration. Either no pain relief or exaggerated side effects will occur with this. We want to assess vital signs, pulse ox, and neurological status every 4 hours. It's important to remember that if anticoagulants are necessary, we need to use another form. No heparin or low molecular weight heparins need to be used with patients that have intraspinal or epidurals in place. We may need to treat the side effects by giving a low dose of naloxone that will work without decreasing the effects of the analgesia. Implantable pain pumps, they are done through the intraspinal catheter placed into the intrathecal space surgically, implanted for long-term pain relief. Usually the pump is placed in the subacute area of the abdomen, and it may need to be refilled every 30 to 90 days. And this is going to be used for your more chronic type patients. Nerve blocks, neuroablative techniques, and neuroaugmentation are referred to as regional anesthesia techniques. Nerve blocks interrupt all afferent and efferent transmissions. They are commonly used during and after surgeries to manage pain. However, they do come with some adverse effects such as dysrhythmias, confusion, nausea and vomiting, blurred vision, and your patient may even complain of a metallic taste. Temporary nerve blocks affect both motor function and sensation. This will typically last from anywhere from 2 to 24 hours, depending on the agent and the injection site. Motor ability generally returns before sensation will. Neuroablations, this is more for severe pain, unresponsive to other therapies. It destroys the nerves to stop the transmission by surgical resection or thermocoagulation, including things like radiofrequency coagulation. Neuroaugmentation, it is the most common use of spinal cord stimulation for chronic back pain secondary to nerve damage that is unresponsive to other therapies. It's an electrical stimulation of the brain and the spinal cord. You may see some other uses include things like complex regional pain syndrome, spinal cord pain, and interstitial cystitis. Potential complications with neuroaugmentation can be from surgery, things like bleeding and infection. nerve damage, and migration of the generator, because it's usually implanted in the subq area of the upper gluteal or pectoris area. When managing pain in the geriatric population, we need to be thinking about some different things that may be different with them versus our younger population. It's an estimated that 50 to 80% of older adults have chronic pain problems. Most of them are from musculoskeletal issues such as osteoarthritis, low back pain, and previous fracture sites. Some barriers to treating the geriatric population with pain control include things like a lot of these patients believe that pain is inevitable for aging. They have a great fear of becoming addicted to these pain medications like opioids. They use words like aching or soreness or discomfort instead of actually saying the word pain. They have a high prevalence of cognitive and sensory perceptual and motor problems. Some examples of these are dementia and delirium. They may have post-stroke aphasia and paraplegia and even some language barriers. So these patients need time sometimes to gather their thoughts and express themselves. Many can't afford the medications, and Medicare and Medicaid have not paid well in the past. So we know, given that a lot of these are on fixed income, they may not be willing to substitute some of their financial funds to pay for these medications to control their pain. We need to think about their hearing and vision defects as well. May complicate your assessment. So pain assessment tools may have to be adapted for the older adult. We need to take time with this age group. They may need to stop and think before they answer your questions, so you need to be very patient with them. Many will wait until the pain is almost unbearable before they want to take medication. And we need to help educate this population so that they can receive the pain relief they need without fear or anxiety. There may be some challenges for you when you assess pain in the older adult, such as the location may be hard to pinpoint because many have chronic conditions and feel pain in more than one area. So you want to ask the patient to touch the area that is hurting the most or provide a drawing where they can point to. When looking at the intensity, we want to make sure the patient understands what the scale you are using means. So tell them if you're using a pain scale of 1 to 10, 1 means no pain, 10 means the worst pain they have ever experienced in their life. And odds are they've had a long life, so they've got something to relate that to. We want to ask about the specific pain they are experiencing. So if they just had a total hip replacement, ask specifically about that pain. When looking at the quality and the pattern, we need to be aware that older adults may have their own way of describing pain. They may call it throbbing pain, or they may say it's jumping or stabbing or poking them. Older adults may not remember when the chronic pain began. It may just have crept up over them over time. So you want to ask them what remedies they have used in the past to ease the pain. You need to know what else is going on with these patients. Are they experiencing other symptoms like dizziness, blurred vision, urinary incontinence, retention, diarrhea? All of these things can kind of help us come to a better resolution for managing their pain. We need to be cautious when treating older adults with pain medications. In older adults, the side effects may occur with a much different dose than in the younger adults. These drugs metabolize much more slowly in the elderly patient. These patients are a risk for GI bleeding, especially with medications such as NSAIDs. They may have multiple drug use interactions, so we need to be aware of changes in any renal and hepatic functioning, metabolism, and clearance of analgesics such as meperidine, methadone, and acetaminophen. They may have cognitive impairment such as ataxia that can be exacerbated by analgesics. They may experience adverse side effects. Older adults are very concerned about their bowel movements and will become very upset if they experience constipation. So we need to be sure to teach them ways to alleviate this problem. Exercise and patient teaching are particularly important and as non-drug interventions for older adults with chronic pain. And family and paid caregivers should be included in the treatment plan with these patients. Incorporating non-pharmacological measures in the pain management plan will help not only reduce the dose of analgesic needed, but it will also help minimize the side effects that come with that. It'll help increase a patient's sense of personal control, bolsters their coping skills, and it's also important for treating chronic pain because it gives them other options to a holistic pain management plan. Some non-pharmacological interventions include things like cutaneous stimulation. Cutaneous stimulation stimulates the inhibitory neurons in the pain pathway and may also serve as a form of distraction. Massage is relaxing to all of us, so for those in pain, especially effective for alleviating stress, creating a feeling of comfort, as well as helping with sleep. Heat and cold applications reduce pain, so we want to be careful when using heat and cold in the older adult. We only use these intermittently and not pretty continuously. You may have heard of what's called the TENS unit, the transcutaneous electrical nerve stimulation. A lot of physical therapy places are now using this. A lot of sports medicine places are using these. It delivers electrical bursts through the skin to both superficial and deep nerves. It's used for patients with chronic pain, especially those with arthritis. You do want to teach the patient to how to place the electrodes and the intensity of the settings, but this is becoming more and more common, especially in treating athletes. Acupuncture, it has been used in Asian cultures for centuries for pain relief. Some have even had surgery using only acupuncture as the pain management. Approximately 100 known pressure points over the surface of the body in patterns called meridians, and it runs bilaterally under the surface of the skin. Acupressure works on the same principle as the acupuncture, but it uses pressure instead of the needles. Cognitive interventions have had good outcomes in most situations. They usually work better for mild to moderate pain, but some people are successful using these methods even with severe pain. These methods create a soothing environment and help the patient to concentrate on other things rather than the pain. Things like deep breathing and progressive relaxation or rhythmic breathing. Music is another good one. You want to make sure that the patient's condition is stable enough to try some of these, especially the massage. Many hospitals even offer music for their patients. Some have individuals who actually go to the patient's room and play an instrument. Guided imagery, we talked about that a little bit earlier, as well as distraction techniques. Hypnosis can also be an effective method of pain relief based on the principle of suggestibility, that it can give the suggestion to alter the character of pain or your attitude about it. All right, let's talk about some barriers to pain management from the nursing perspective. None of us want to be a barrier to pain medicine, but it happens every day. Many nurses still fear that they will over-medicate the patient or create an addiction to the medication. Sometimes it's from that we don't have the amount of knowledge that we think we need to be able to assess and treat pain adequately. Sometimes it becomes a lack of time problem or expertise. When you are a new graduate nurse out there, you are maybe a little bit more cautious about giving patient pain medications versus a more seasonal experienced nurse. Sometimes nurses have the unwillingness to believe what the patient says their pain is. Sometimes we think, well, how can a patient have a pain level of 7 if they're in there on their phone all day talking? They don't seem to be in pain to me. Well, that can be a misconception of some things, because sometimes you think about it, if you're in pain, you do things you wouldn't normally do to either distract yourself or kind of turn away from it. Nurses also sometimes get very concerned about regulation of controlled substances. We all know how this is. Every time you go to the Pyxis and you pull out a pain medication such as an opiate, you have to count how many are in there. You have to type it into the Pyxis, and then of course if it flags an error, we're all worried about being the one that's going to flag the error and something happened to. We do sometimes kind of fear that our client's going to become addicted. We think if we have that patient that has been asking every 4 hours on the dot for their pain medication for the last 3 days now, then we think that this is going to become worse of a problem. Nurses usually will tend to be more concerned about the side effects. We always think, well, what if I over-medicate them? What if I knock out their respiratory drive? What if I bottom out their blood pressure? So that never needs to be a reason to hold pain medication. We need to treat the patient and adjust to the side effects as we need to. Nurses should rely on evidence-based practice rather than doing something else because it's what we've always done or some kind of myth or wise tale. We need to monitor the patient's pain and seek out new medications if their current ones aren't relieving the pain. There's times where you may tell the doctor and say, hey, this patient, morphine isn't relieving this, but in the past I've given them some Valium and that seems to have helped. Okay. Never be afraid to question the current orders and to seek out new ways to help alleviate your patient's pain. Some barriers to pain management from the patient's perspective. Sometimes our patients are very reluctant to report pain. So education is the key to helping patients understand the medications and the way that it affects them. Patients are sometimes concerned about not being a good patient. They want to please their nurse because the nurse is the one they trust taking care of them. So they feel like if they don't tell you they're in pain or they don't ask for pain medication, that you won't think that they're a nuisance or that you're bothering them. Patients can be reluctant to take pain medication, especially with the fear of addiction. Fear of addiction should not be considered when discussing pain medicine. We must help them to understand that addiction only occurs after usually a very long use, and it should not be concerned for the short period that we're trying to manage their pain. Sometimes patients don't ask for pain medications because they don't want to bother you, especially the elderly client, so you need to ask them a little bit more often. You may have to get creative with assessing their pain. Some patients believe that admitting they're in pain means that the disease is worsening. This becomes a denial thing for them. You must work with your patients to understand these fears and to help them overcome them. Let's look at some other barriers to effective pain management. Tolerance is built up when larger doses of medicine are needed to provide the same amount of pain relief as when the much smaller dose would have been effective. Usually occurs when the medication is taken over a long period of time. The opiate receptor becomes less sensitive to the medications, and you need to add a non-opiate to the medication or switch it completely. Although tolerance isn't as common, we need to assess patients that are on long-term therapy to evaluate and rule out other causes of increased analgesic needs, such as if their disease has progressed or they have developed another type of complication. If significant tolerance to opioids has developed and it has lost its effectiveness, then we need to rotate or look at the option of rotating their opiate medications. Physical dependence. It's the expected response to an ongoing exposure of a pharmacological agent manifested by a withdrawal syndrome when the blood levels dropped abruptly. So this means that your patient will have signs of withdrawal if the substance is stopped. Usually you may see this when the patient runs out of the medication and they've been able to get it refilled. They will usually show up in the emergency room displaying physical symptoms of the withdrawal syndrome. So we've talked about before some side effects of withdrawal, things like anxiety, irritability. They may be having hot flashes. They may be drooling everywhere. They may have snotty nose and salivation. They may be diaphoretic. Patients can complain of nausea and vomiting, abdominal cramps. I have even seen where they have become severely tachycardic and their blood pressure has shot up out of the roof. So We can avoid these withdrawals by weaning the patient off the medication slowly. And generally, these patients are placed on a tapering schedule to avoid withdrawals. Addiction. Addiction is a compulsion to take a substance primarily for the psychological effects of it. This is can be kind of rare. It's a tolerance and physical dependence are not indicators of addiction. Risk factors for becoming addicted include things like your younger population, family history of substance abuse, or even patients with mood disorders. The risk of addiction, however, should not prevent nurses and doctors from using opioids to treat moderate to severe pain. Do not withhold pain meds. Everyone has the right to pain relief. It can be very challenging to to manage pain with patients that have a history of substance abuse, especially if the drug of choice is opioids. But it is important to remember that patients have a right to pain control. Nurses need to do a comprehensive assessment. We need to remember that withholding opioids from chemically dependent patients with pain has not been shown to increase their likelihood of recovery from addiction. So we cannot say that we're not giving you any so that you don't become addicted. Opioid agonists and antagonists should not be used in this patient group because they may precipitate withdrawal symptoms. And individuals who are tolerant to CNS depressants, they may need larger doses of opioids or increased frequency of drug administration if necessary to achieve pain relief. Some other ethical issues are things such as fear of hastening death by administering analgesics, request for assisted suicide, and the use of placebos in pain assessment and treatment. These are very common concerns by nurses and physicians. There's no scientific evidence that opioids can hasten death, even when patients are near death. So by you treating them in a terminally ill situation, it is not going to bring it on any faster. Unrelieved pain is one of the reasons for such requests. Making sure the patient is comfortable should decrease the number of these requests. Placebos are still sometimes used to assess and treat pain. This is deceiving to patients, and the practice is condemned by several professional organizations. Healthcare providers have given patients placebos when they thought the patient wasn't really in pain. And while it is non-ethical for us to do this, research has shown actually that 30 to 70% of those receiving the placebo when they were told it was pain medication, would relieve their pain. Relief of pain after administration of placebo is due to the initiation of the body's endogenous opiate response. So it's a very temporary response and is activated by the expectation of a positive result. So even if the placebo worked, it does not mean the patient wasn't really in pain. Placebo response does not indicate the absence of real pain. Okay, let's talk about addiction and substance abuse. Substance abuse and addiction are serious problems affecting society and the healthcare system today. People become dependent on psychoactive agents that results in a pleasure or modifies thinking and perception. These substances can be illicit or even legal drugs. Some examples for legal drugs would be things like cigarettes and alcohol. And illegal drugs would include things like marijuana, cocaine, heroin, inhalants, hallucinogens, and even prescription drugs that are used for non-medical purposes. Abuse of prescription drugs seems to be increasing. We seems to be in a big opioid crisis right now. As substance abusers use healthcare system more than those who do not. Usually we term these as drug seekers. And 1.7 million visits to the emergency department in 1 year due to substance misuse or abuse. There are 4 different terms that we're going to talk about with some substance abuse terminology: addiction, dependence, tolerance, and withdrawal. Addiction means that you've got a compulsive, uncontrollable dependence on a substance, practice, or behavior, despite its negative or dangerous effects. Dependence is where you become resilient to the substance and it's reached the level that absence of it will cause an impairment of function, meaning that a person needs the drug to function normally. A person may have physical dependence on a substance without actually having a addiction to it. Tolerance means that there is a decreased effect of a substance that results from repeated exposure, usually needing a higher dose to attain the same effect because the body adapts to the presence of the drug, that the lower dose no longer has the same effect. Withdrawal is the physiological and psychological responses that occur when our body has become dependent on a drug and then it is abruptly stopped or reduced, and the patient no longer has it. Usually this is going to occur within the first 24 to 48 hours after stopping the drug. We're going to talk about some common drugs of abuse. We're going to go over nicotine, alcohol, stimulants, depressants, and cannabis, otherwise known as marijuana. Nicotine is one of the most rapidly addicting drugs that is commonly used. It is a stimulant found in tobacco products. The smoking portion is the most harmful method of nicotine ingestion, while it is not the only way. The big thing here lately has become the vaping and the effects on the respiratory system. Effective nicotine on the brain is similar to other highly addictive stimulants such as cocaine. And nicotine has been related to lots of different types of cancers, such as lung cancer, pancreatic, colon, cervical cancer. And it also has a lot of impact on chronic diseases such as strokes, heart disease, emphysema, even hardening of the arteries known as coronary artery disease. So nicotine plays a really big role in someone's overall health care. Joint Commission mandates that every health professional is responsible for identifying tobacco users and providing them with the information on ways to stop. Most healthcare facilities are now tobacco-free environments, such as hospitals, nursing homes, and clinics. And patients who are addicted to nicotine may experience withdrawal symptoms. This is why when we admit a patient, we always ask them about if they are a smoker or a nicotine user. And if they are, we will generally get them an order for a nicotine patch to wear while they are in the facility itself to prevent this withdrawal. There are 5 questions that we are supposed to ask for individuals who desire to quit, such as the ask, advise, assess, assist, and arrange. And then there are 5 R's for those who are unwilling to quit. And we use these with motivational interviewing. Remember, it is your job to present them with the information and the resources to quit, but it is not your job to try to coerce them or force them into something that they're not willing to do. Participation in tobacco cessation programs is recommended in conjunction with some nicotine replacement therapy. Patients that have done both a combination for a year are twice as likely to be able to quit. Some nicotine replacement agents that you might see used are things like nicotine gum, lozenges, the nicotine patch, or they even have inhalers and nasal sprays. Non-nicotine agents that are medications that we have found to be helpful will be things like clonidine, helps reduce withdrawal symptoms. Chantix blocks the effect of the nicotine on the brain, trying to tell the body that it more or less doesn't need it. And then, of course, Zyban reduces the urge to smoke and withdrawal symptoms as well. It helps also prevent the weight gain that occurs. Remember, when someone is trying to get rid of one habit, they will generally replace it with another. So for someone who is trying to quit smoking, that generally falls in the quarters of where they want to eat more, and that is where a lot of this weight gain comes in. Let's talk about alcohol in the United States. About 38 million adults in the United States are considered to be where they drink too much. Only 1 in 6 has really talked about it with a health professional. And so drinking, if a patient is drinking too much, it'll include some of these things. When a patient is admitted to the hospital, it is your responsibility as the nurse to ask them about alcohol. Now, some will be honest with you and some will not, but you are to document what they tell you. So if for men, binge drinking is considered for being things like 5 or more drinks consumed on one occasion. And one occasion means within usually 2 to 3 hours. And for women, it's a little bit less. It's about 4 or more drinks. We want to address any alcohol issues used by pregnant women. Um, Alcohol use by those under the age of 21 is very interesting and concerning that when we think that almost half of Americans 12 and older consume alcohol, and we shouldn't even be talking about the age of 12. That shouldn't even be an issue, right? But these teenagers are getting younger and younger with consuming alcohol. For men, we're looking on an average per week if they have 15 or more drinks on average per week, or for women, it's 8 or more drinks on average per week. That is considered to be drinking too much. Alcohol affects almost all body cells. It causes an increased level of dopamine in the brain, but suppresses all areas and functions of the central nervous system. Its effects are related to the concentration of alcohol and individual susceptibility to the drug, which one person may handle 5 drinks better than another person handling 5 drinks. So it's different for everybody. Those who abuse ETOH, known as alcohol, have many health problems related to that. They can have encephalopathy, which is inflammatory or a hemorrhagic degenerative brain condition. They can have Korsakoff psychosis, which is an irreversible form of amnesia characterized by loss of short-term memory and inability to learn. The alcohol has interactions with medications, so we need to make sure we educate our patients when we are prescribing them or discussing medication education with them. To a lot of these medications, they cannot drink alcohol with, period. So, for instance, alcohol combined with aspirin increases GI bleeding. Alcohol combined with acetaminophen increases risk of liver damage. And then, of course, any kind of your psychotropic drugs or anti-anxiety medications increase the effect of CNS depressants. Alcohol withdrawal syndrome. This is when the ingestion of alcohol is abruptly stopped. This is why it's very important for nurses during a hospital admission assessment to address if your patient drinks alcohol and if it's on a pretty routine basis. Because a hospitalized patient can develop withdrawal syndrome, and usually you're going to know when it's going to happen because usually it's within the first 24 to 48 hours. And you need to be monitoring for some signs of this. You need to be prepared. Onset and symptoms usually depend on the patient's drinking pattern. Environment should be kind of really calm and quiet to kind of avoid the symptoms worse. We need to be thinking about adequate nutrition. This is usually where you're going to see patients on what's called a banana bag. It's kind of this big IV bag that's got a lot, it looks yellowish, that's why it's called a banana bag, but it's got a lot of nutrients and minerals in it. We want to make sure that they're usually on some type of thiamine to help with metabolism. And sometimes you will see physicians give you an order for things like Ativan or Valium, some type of benzodiazepine to kind of help reduce the effects of developing withdrawal syndrome. Alcohol withdrawal delirium. This can be a very serious complication. Your patient may become disoriented, visual or auditory hallucinations, and they also have an increased hyperactivity without any type of seizures. These patients will become very hyperthermic, which can result in death or cardiac failure. I've actually had a patient one time that came in. I was a young nurse on a med-surg floor that he was actually in there for alcohol detox, and he was admitted for having withdrawal symptoms. And this man was running around like a crazy fool. He was a big guy, probably 6 foot tall, 300 pounds. And I was a young nurse, so when I called the doctor, he gave me an order I remember he gave me an order for Ativan, and he gave me an order for Haldol. And he told me to give this man, I think it might have been like 2 milligrams of Ativan and 5 milligrams of Haldol every 30 minutes until he dropped like a rock. And I think it took me about 6 doses of each to finally take this man down. And when he did fall like a rock, but he wound up sleeping for 3 days. And so when he woke up, it seemed to be a little bit better. But the important thing is I want you to remember that alcohol withdrawal has serious physiological effects on the body, and it's not psychological, and that it can be harmful and cause these patients to go into cardiac arrest and even death if it's not managed appropriately. Some symptoms you might see with minor effects of alcohol withdrawal will be things like anxiety. They may have some tremors. Their heart rate's going to be a little bit more tachycardic. Their blood pressure is going to be up. They may be diaphoretic. They may complain of nausea. They may be experiencing some insomnia, or like I said, the hyperactivity without the seizures. They'll be running around like a rat, okay? Very, very kind of hard to manage. So some things we can do, the benzodiazepines, like I said, they are fantastic, whether it be Ativan or Valium. Those are usually two popular choices to help kind of stabilize things. It'll decrease the anxiety and prevent seizures. Thiamine, all right, thiamine is fantastic to helping with preventing encephalopathy as well as metabolism. Multivitamins, that's where that banana bag's going to come in, that folic acid, and there's a lot of B vitamins in there, and there's a lot of magnesium as well as the glucose, all combined in the banana bag. So you will generally see this ordered on these patients. Patients that are experiencing some major alcohol withdrawal, they've already kind of gone through some of those minor symptoms, and now they have worsened to the point to where your patient can be having seizures, they can be delirious, they can be having gross tremors, or they can be having this visual and auditory hallucinations. We're going to continue the benzodiazepines. We're going to probably put them on Dilantin, and now Keppra has become the new big thing for seizures, as well as Thorazine and Haldol is fantastic antipsychotics for helping manage some of the psychosis in these patients. These patients are going to generally be in the critical care units because of the physiological effects that this can have on their body. After nicotine, one of the most abused drugs are considered to be cocaine and amphetamines. While cocaine is illegal, amphetamines they are legal as prescribed, things like Ritalin, all right? These work by increasing dopamine in the brain. Ritalin is commonly used to treat like narcolepsy, attention deficit disorder, and some of these amphetamines are even used prescribed for weight control. All stimulants work by increasing the levels of dopamine in the brain. That way, when that happens, you kind of get this feeling of euphoria and alertness, but it also can cause a rapid dependence. Okay, it's a stimulant peripheral nervous and cardiovascular system, so it kind of creates a adrenaline-like effect. So early on, you may have things like euphoria, excitation, restlessness. Your patient may experience some tachycardia and some hypertension and dysrhythmias. That's why patients that are actually prescribed these things, they need to have a good physical history done. Okay. Long-term effects from these can actually be things like depression, hallucinations. It can have some cardiac effects, things like heart failure, myocardial infarction, and even cardiomyopathy. Almost 500,000 people a year are treated for cocaine and amphetamine use. So overdose is a very frequent problem that we experience. Some things that you might see when you're assessing for toxicity, symptoms would include things like agitation. They're going to be hyperthermic. Their temperature is going to be high. Heart rate's going to be elevated. Blood pressure is going to be elevated. And even their respiratory rate's going to be elevated. We want to monitor these patients for dysrhythmias. They can even have some lethal dysrhythmias. They are high risk for having a myocardial infarction and even seizures. And death is often related to strokes, fatal dysrhythmias, or even having a myocardial infarction. Withdrawal causes few physical symptoms. They may have things like severe cravings. They're trying to eat the refrigerator out. Prolonged sleep periods, much more normal than you or I, or they may seem to be really depressed or irritable. When we're assessing a patient for cocaine and amphetamine toxicity, some things that we might find in our assessment include things like heart palpitations. They may complain of their chest palpitating. Their heart rate's going to be tachycardic and their blood pressure is going to be elevated. They may have some dysrhythmias on the cardiac monitor. I've actually had a patient before that has had a myocardial infarction from cocaine use. This lady was celebrating her 50-year birthday. It was a big celebration for her, and for some reason she felt like it was a fine time to experience cocaine at the age of 50, and found herself a trip to the cath lab after having a acute myocardial infarction. These patients may seem to be agitated or combative. So if you have patients that are coming into clinics or the ER, even admitted to the hospital itself with this type of issue, you might want to kind of keep security on hand. Don't try to fight with them, because trust me, they think they are way much stronger than you are. They may have some experiences of euphoria. We do want to monitor for these patients for seizures, so they need to be on seizure precautions. And hallucinations can sometimes make it very challenging for the nurse to manage as well. So some interventions that we want to do to care for these patients: we always maintain a patent airway, especially if they've got an altered level of consciousness. We're going to be giving them IV fluids. That's going to definitely help kind of keep their cardiovascular system going. We're going to have them on a on a cardiac monitor, excuse me. We'll treat any dysrhythmias that they may have. Your patients may be on antihypertensive medications, especially depending on how high their blood pressure gets, because we don't want them to get into a hypertensive crisis and be more at risk for having a stroke or a myocardial infarction. These patients, we give Valium or Ativan to help prevent seizures as well as treat seizures. And they may be on some antipsychotics. Usually Haldol is a very popular one for treating the psychosis and the hallucinations. Besides alcohol, barbiturates and benzodiazepines are some of the most commonly used depressants. They're more frequently able to produce that euphoric effect. They will also cause things like impaired judgment, slurred speech. They can have a physiological effect such as hypotension and bradycardia, and your patients will have constricted pupils. The reason is that these sedatives will depress the central nervous system and cause sedation at lower doses and sleep at higher doses. However, your patient is able to develop a tolerance very rapidly. So overdose is something that we definitely have to monitor for. This has become a very common thing out on the streets because we see a lot of kids, especially taking things like Xanax, where they're calling them blue bars or whatever else they're calling them. So some symptoms your patient may have if they have overdosed on barbiturates or benzos will be things like shallow respirations. So the respiratory system is the biggest problem. They can have a weak, rapid pulse or hyporeflexia. And usually overdose can result in death because it has such a respiratory depressive effect. So how can we treat an overdose with benzodiazepines? The antidote drug for that is known as romazicon. Now, it's important to remember that with romazicon, if your patient has become dependent on benzodiazepines, or they're on it for some type of seizure disorder, when you give this medication, it's going to bind to it. So it's going to create withdrawal symptoms. So we are going to probably decrease their seizure threshold. So when we administer this, we want to make sure that we monitor this patient's airway, that we have stuff in the room to be able to treat an airway issue, and that we also are able to treat seizures, and we have seizure precautions in place. Some other things we can do to help treat overdoses of these are they may go to dialysis. We know that dialysis can decrease the drug level by pulling it out of the blood system. Or you may do a gastric lavage or be ordered to give activated charcoal, especially if this medication has been taken within the last 4 to 6 hours. Now, it's important to remember that when you're given activated charcoal, they are not going to like it. It's like a dark charcoal. It tastes nasty. They can either take it orally, it's in a liquid, or you can put it down an NG tube. Now, if you're given activated charcoal with sorbitol, what goes down is going to probably come back up. So when you administer this to this patient, it's going to bind to the medication down in the gastric system. So a lot of times these patients are going to want to start vomiting it back up, or with the sorbitol, it's going to make them have it come out through the stool and create diarrhea. Some symptoms we want to monitor: withdrawal. We've talked about this before. Early signs of withdrawal are things like restlessness, insomnia. They may have orthostatic hypotension, or they may be disoriented, as well as we want to monitor for that hyperthermia, that temperature to go up. If it's been 3 to 5 days and they start having severe withdrawal symptoms, that is where we talked about that psychotic delirium. They can have a higher risk for seizures as well as cardiovascular collapse. When assessing a patient that we think might have overdosed on a depressant drug, there's some things that we might find during our assessment. Usually for me, a high suspicion, things like if they're very lethargic or stupor, that's one, but they can also switch gears and have a very aggressive or agitated behavior. They may have hallucinations and have slurred speech with pinpoint pupils. When you're assessing their pulses, they may be rapid and weak. And remember, this is not a good thing, okay? Because a rapid, weak pulse tells me that my patient's kind of shocky and it's trying to perfuse organs. They may also have hypotension, that low blood pressure. We are trying to increase our cardiac output to perfuse organs. This is also where the cold, clammy skin comes in. So remember, your patient is in some form of shock, more or less a hypovolemic type shock with this depressant overdose. So some interventions that we can do: always a patent airway. Airway is always a big problem with overdose of a depressant drug, because remember the effects on the respiratory system. These patients need IV access. We need to try to get some information about when they took the substance, what they took, how they took it, and how much. And a lot of times, be honest, with the way that these kids are having parties these days, they may not even know. They put all these pills in a bowl and they just start taking them. They have no idea. But try to collect some information if you can. We can do drug levels and tox screening. So a lot of times, remember, you're going to be getting some blood drawn and urine samples on these patients, because a lot of times when we run them, we can tell what they have actually got in their system. We may not know which drug it was, but we can identify the classification, and that will help us. We can administer the antidote. Remember, we talked about, especially for benzodiazepines, that romazicon is the antidote to treat with, and that is given IV. It can be given IM, but it's preferred IV. Gastric lavage if necessary, and we've already talked about giving the activated charcoal. Opioids. The opioid crisis has become the big hot topic in today's world, right? So there are a lot of different types of opioids that you may see and hear about. Some of them you're going to even administer in the hospital. So opioids fall in the class things like heroin. Heroin, some other street names you might hear for heroin, because it is making its way back into the streets. Maybe things known as brown sugar, dope, smack, junk, things like that. Morphine, opium, codeines, fentanyl, the meperidine, Demerol, we still give those a lot in the hospital. Fentanyl, we still use a lot in the hospital. Hydromorphone, known as Dilaudid. Oxycodone, known as Oxycontins. Those are all some common drugs that we use in the hospital still as well. Heroin and fentanyl are commonly used street drugs, but now today we have found that a lot of these patients, that is why the FDA is really kind of cutting down on the amount of opiates that physicians can actually prescribe. We've changed a lot of laws now that you can't no longer call in a prescription to the pharmacy over the phone. A patient actually has to hand deliver a written script to be able to get these medications because of the issues. IV use of oxycodone has become an epidemic. To be honest, I don't really know how or why they want to be crushing up these pills and giving it IV. Opioids can cause CNS depression along with some other effects. Patients, or actually not patients, people that like have an opioid addiction, they like it because it creates a euphoria and an analgesic effect. Some other things that it's going to cause are things like relaxation and drowsiness. Constipation is a big side effect. Maybe they ought to tell them that before they start taking all this on the streets, right? It can decrease their respiratory effort and then cause impaired judgment. And if they take too much, overdose symptoms would include things like shallow respirations, right? We're knocking out that respiratory drive, constricted pupils, and they can even become comatose. We've talked about this before, but the treatment for treating opioid overdoses is Narcan or naloxone. Remember, we can give IV as preferred, the quickest route. We can give it IM if necessary. In fact, a lot of your first responders like firefighters and police officers are now carrying Narcan injectable IM kits with them. So when they come on these scenes, and this is the case, they can go ahead and administer the Narcan. It is important to remember, though, that these patients can still, they're dependent, so they can still have those withdrawal symptoms of abdominal pain, nausea and vomiting, that increased temperature, tremors, elevated heart rate, blood pressure, and so forth. Injected IV, if they're taking anything that's injected IV, these do fall in a high risk population for developing HIV, hepatitis B, and hepatitis C. It is the responsibility of nurses to assess patients, all patients that come in, and screen them for the use of substance abuse. The problem is a lot of these patients may be afraid to tell you because they are afraid you're going to report them to the legal authorities. Federal privacy laws actually prohibit nurses and doctors from disclosing treatment of substance abuse without written consent of the patient. So a lot of times I will tell these patients, I don't care what you're taking, and I don't care to tell anybody. I just need to know what it is so that I can treat you for it. Okay, that's why I can properly take care of you. Nurses need to be observant for these patients for different behaviors like denial or avoidance, underreporting, or minimizing substance abuse. A lot of times patients don't want to admit that they have a problem, even if they do, or they deny that their problem has not gotten as bad as they think it would be. It's important for us to be non-judgmental. So we need to tell them, like I said, I tell them, I don't care what you do, I just got to check the box. And sometimes when you play it down a little bit like that, then they don't think that you're going to be looking at them wrong. So we need to make sure we ensure confidentiality and privacy and let them know that it is not legal for us to pass on their information or to call the police or anything of that matter. Some overall goals. We want our patients to have normal psychological functioning. We want to get them to acknowledge that they have a substance abuse problem. We want to be able to offer them the appropriate resources and help that they need. We can explain the psychological and physiological effects of substance abuse on their body and do a lot of patient teaching with them. Health promotion is really a prevention and early detection of the abuse. So this is where we talk a lot about education, about the negative outcomes of the use of addictive substances. Acute intervention includes dealing with acute intoxication, overdose, and withdrawals. This has become a big problem with pain management because nurses and doctors are very reluctant to give opioids to substance abuse patients for fearing that it's going to promote or enhance the addiction problem. There's not any evidence that really shows that by treating patients' pain in the hospital that is a substance that has an addiction will worsen their addictive disease. It's already there, right? There are some guidelines for pain management in patients with addictive diseases, especially if they are already going through cessation clinics like methadone. If a patient is on methadone in a pain management clinic because they're trying to come off of them, then there's a little bit different guidelines for managing their pain. Motivational interviewing. It's a very good way to do non-confrontational communication techniques to try to help motivate the patient to change behavior. This is something, though, that you do need to kind of have a competency or some practice with. And ambulatory and home care. This is really treatment and rehab is considered after acute health care problems are resolved. Patients may decide to go to inpatient treatment therapy centers or to maybe even do some outpatient treatment as well.